handout that we're going to be looking at is this one here.
That's the one you sent this morning.
No, this one I probably sent. Did I send this one?
Yeah, this was last week.
Oh.
I gave it down to us last week.
Yeah. Yeah, I sent this last week, so. But basically, okay, over here we start out with what the definition of ventilation and perfusion is. Okay. So basically the movement.
What page did that look like?
That is the top page.
Okay, thanks.
Okay. Okay, so in understanding what the lungs actually do, so ventilation, moving air in and out, respiration, okay, that's the gas exchange, and remember that only occurs in the alveoli through a process of diffusion. Okay, and then perfusion, that's the study of blood moving into an organ. So we do perfusion scans of kidneys and lungs and things like that. So when we do a perfusion lung scan, okay, we inject our radiopharmaceutical intravenously, and what we're basically doing is looking at the blood flow into the lungs off the pulmonary artery. The other thing I put in here that's important that the lungs do is regulate the acid and basic components of the blood. So I said when the pH is increased when carbon dioxide is decreased. What does that mean in English?
Blood becomes more basic as the bicarbonate goes down.
Okay. Yeah. So when you blow out a lot of air, your blood becomes more acidic because you're blowing out carbon dioxide. When your blood is more basic when you blow out a lot of carbon dioxide. Your blood becomes more acidic when you retain it. Does that make sense? Okay. Because patients that have diabetic, what they call ketoacidosis, they have what they call Kussmaul's breathing. And that's where they have this very deep, fast breathing, and their blood becomes very acidic.
And their CO2 goes down.
Their CO2 goes down. Okay, remember, when people become they hyperventilate because of anxiety, yeah, their blood becomes more acidic. They can't catch their breath. They feel like they can't breathe. So, and then the other thing that we want to be aware of here are the terms, what tidal volume is, total capacity. So notice tidal volume is the amount of air that moves with each breath. Total lung capacity. This is where if you have a respiratory test, they'll tell you to take in a breath and keep going, breathe in, breathe in, breathe in, breathe in, breathe in, as much as you can. And then the vital capacity is how much air you can exhale. So they'll tell you to blow out, blow out, blow out, blow out, blow out. Okay, and then anything that's left in there after that is your residual volume. And then the functional residual capacity is the amount of gas in your lungs at the end of just a normal breath. Okay. Like I said, the majority of reasons why we do this test is what? Okay, we're mainly looking for pulmonary embolus. So a lot of these, well, there's a few things. Okay, we're also looking for chronic obstructive pulmonary disease because a lot of times with those types of people, we have to remove a lung. I don't know if any of you have done quantitative lung scanning. Anybody done that yet?
Differential?
Well, I don't know if they call it differential. I mean, it's
Calculating how many counts were in each lobe or area like that?
yeah. Yeah, that's what it is. Because what we're trying to do is figure out which lung we're going to take out. Because what's happening is when the lung becomes all scarred, it causes back pressure, which causes the heart to go into failure, right-sided failure. Not cord pulmonale, but what happens is you'll have right-sided heart failure, and so then blood will start backing up in the extremities, and you'll get edema and things like that. And so what will eventually happen is they have to cut out one of the lungs in order to decrease the pressure in there. So we're going to be talking about emphysema. Okay, this is where the alveoli start breaking down. This does affect our lung ventilation and perfusion scan. The fibrosis, and I listed here asbestosis is one, but there's also silicosis and a few other ones that inhaling dust. Pneumonia, okay, that affects our lung scan. Congestive heart failure or any other type of edema. So if you have pleural effusion, okay, or CHF, cancers affect us, atelectasis, partial or complete collapse of the lung. And then here's our favorite here, and this is what I want you to pay attention to. There's about 600,000 cases of pulmonary embolus a year. Out of that, well, you know, they estimate 6 million, but documented we have at least 600,000. At least 100,000 people die from it, so it's like the third or fourth leading cause of death. Notice that most pulmonary emboli occur in the deep veins. So what might be a handy little test to have is an ultrasound. There's basically 4 types of clots that we deal with. Okay? The one that you're most familiar with is the blood clot. However, if a person fractures their femur, we get fat globules that are released. You know, the yellow bone marrow gets into the bloodstream. Now, these ones are going to cause difficulty breathing, but the problem is they're so small, we typically won't see them on a lung ventilation perfusion scan. Okay? They just won't show up. A woman who's been pregnant and just recently delivered, okay, amniotic fluid that gets into her blood, that will cause embolization too. Now, we normally deal with the venous thrombi, but notice that if a person is having cardiac problems, you can form clots on the inside of the heart. And when those get pumped out, that's when you have things like stroke and obstruction of blood flow to organs and things like that. Okay? So anytime the blood is sitting around and not moving, especially in a left ventricle that's fibrillating, you can have clots form. And then it's not uncommon for us to, when we resuscitate them, to have strokes and things like that. Now the symptoms I really want you to pay attention to, because when you're getting a history on these patients, you need to show that some of this stuff is appearing. Okay, the chest pain, difficulty breathing, coughing. Sometimes when the blood clot causes pulmonary infarction, so we kill the lung tissue, we get bleeding, so hemoptysis. Everyone know what hemoptysis is, right? Yeah, coughing up blood. Okay, on a physical exam, the patient is going to be tachycardia. Okay, what's tachycardia?
Fast heartbeat.
Okay, fast heartbeat. But you need to define what a fast heartbeat is, because what's normal resting heart rates?
80 to 100.
Ooh, a little bit high.
60 to 100.
Yeah, for adults it's 60 to 80. Normally ours, you don't have resting heart rates over 100, or at 100. 60 to 80 is considered typically that. Okay, and the other thing about tachycardia is you got to look at the EKG. You guys have all had EKG class, right?
Yes.
Okay, so on a tachycardia, what's the difference between that and ventricular tachycardia?
Extremely high, about 200 or 180.
Yeah.
180 up. 180 up.
Well, okay, the other thing is that if you look at the EKG, you're still able to see PQRST complexes on tachycardia. You don't see it on VTAC.
Oh, yeah, it's just.
Originating in the ventricles.
Right. And the thing about VTAC is that there's no blood pumping because there's not enough time for the ventricle to fill
Isn't
with
it
blood.
like a weird, like a
Like the
BBC?
McDonald's sign?
Yeah, it looks like a big spike. You don't see any of the other components. Okay. So tachycardia, and hypotension?
That in turn leads to kind of hypertension, right?
Yeah, why would you have hypotension?
Stroke volume goes down because the heart is pumping so fast.
Yeah. But in the case of a PE, why would you have hypotension? Okay, you're blocking a lot of blood from leaving and going into the left ventricle. Okay. You may have a fever and you may have fast breathing. Okay. Normally, at what point do you consider fast breathing where you probably have to do CPR? What's normal respiratory rate?
It's around 16.
That's about 12 to 20. Okay. When you get over 30 breaths per minute, you have a severe breathing emergency. So, tachypnea, anybody who's more than 30 breaths per minute, you're probably going to be doing CPR on it. Okay, the other thing is, we don't normally just do lung ventilation perfusions because we think they may have a blood clot. We are going to get an ABG, so an arterial blood gas. Okay, normally should have oxygen concentration of 80 to 100%. Typically with a severe pulmonary embolus, 65% or lower. Okay. Chest x-ray, they may have normal chest x-rays. Usually if we have an area where there is pulmonary embolus, you won't see the vasculature continuing out into the lung fields. So in other words, a chest x-ray, you should look relatively normal, but you may have decreased vascularity in the lung fields. You also may have dilations of pulmonary artery. Okay. So, let's go back here and take a look at the lungs then. Okay.
What's the hypertension again?
Well, because you're blocking blood flow leaving the heart, or going from the heart to the left ventricle. Okay. So, okay, this is what's going on here. So the air goes in. Now remember, there's two components of breathing. You have an active component, which is where the muscles, the diaphragm, the costal muscles all, contract. That causes a decrease in pressure in the chest. Does anyone remember what the normal atmospheric pressure is? Okay.
Millimeters of mercury.
Yeah, it's 760 millimeters of mercury. When you breathe in, your chest pressure lowers by about 5. So it drops to about 755 millimeters of mercury. So air rushes in. Okay? About 5 millimeters of mercury. It's not very much. And you'd be surprised how weak your muscles are. One of the experiments that we did when I was a student at Cal State LA, we went swimming in the pool. And you know how people, when they're swimming, they'll take a hose and go underwater and they'll be breathing? Okay, you can only go down to about 1 foot and still do that. If you go any further than like about 2 or 3 feet, the pressure is so high you can't breathe. That's why if you do scuba diving, you have to have a regulator.
What's the pressure of water at 1 foot?
It's 33 atmospheres, so it's about 33 times 760. It's a lot of pressure. You'd be surprised how difficult it is. I mean, when you're under there trying to suck through a hose, because You know, when I was a kid, I thought, wow, that would be really cool to go down at the bottom of the pool and with a garden hose and suck. Yeah, and then you can't do it. Okay, but anyway, so we're going to talk about the anatomy here. Okay, remember when the air comes in, we have sinuses. What are the purposes of the sinuses?
Filter and warm up the air, humidify it.
Okay, filter, warm, and humidify. Okay. Also, you have the ethmoid bone in there that gives you the sense of smell. Okay. So, why do you need to warm the air? Didn't you? Why do you need to warm air?
It's more comfortable.
Yeah, you don't want your organs uncomfortable. No, actually, it's so that you don't become hypothermic. You don't lose too much body heat. Okay, why do you humidify it?
You don't want too much fluid in there?
Huh?
Too much fluid in the air? Too much moisture in the air? Something like that?
Too much moisture in the air. What if you're out in the desert? Okay, you don't want to dehydrate. Yeah, well, you don't want to dehydrate your body, because if you did not humidify the air, you would lose too much moisture. So you don't want to breathe through your mouth. Okay, when you breathe through your mouth, you lose a lot of moisture, and you can dehydrate. Okay? So now you know all that good stuff. Okay, so we have the sinuses that do that, and then we have the we have the epiglottis. Remember, what's the epiglottis for?
Prevents anything entering the trachea besides air.
Okay.
It blocks the
Blocks the trachea when you swallow. So then you don't aspirate and have stuff go into your lungs, right? Okay, then we have the primary bronchus. We have the trachea, and we have two primary bronchus. Let me just go to the next picture here. I don't care if you know about the vocal cords or anything like that. By the way, that singer's node that Adele had removed, that's a very common procedure that we x-ray. I just thought I'd throw that in there. Because as soon as they said that she had that surgery, I said, she's got a singer's node. And that's exactly
It looked like it was all.
well, I mean, it's a big deal. You can lose your voice. The surgery is very risky, and it always has been, but you know, they did it with the laser, so that was pretty good. But anyway, so here's the trachea. Remember, we've got two primary bronchus, the left and the right. One of the questions that they often ask you on anatomy is, if you aspirated something, which bronchus is it more likely to go into? The right. Well, notice that it's bigger and it's straight down. So stuff that you aspirate normally goes into the right bronchus. But then we have what they call the secondary bronchus. So you notice that in the right lung, how many secondary bronchuses do we have? Three. Yeah, because you have an upper lobe, a middle lobe, and a lower lobe. Okay? In the left lung, you have two. You have an upper and a lower lobe. Okay? Then you have what we call tertiary bronchi. And one of the reasons I threw that in there okay, and on your handout, I've listed the 18 segments that are supplied by the tertiary bronchi, because these are the segments that we look for to be knocked out when you have pulmonary embolus. Okay? If you have a pulmonary embolus and it takes out one of these segments, that's what we're going to see on the lung ventilation and perfusion scan. Normally, if we see more than one segment knocked out, that's highly suspicious of pulmonary embolus. Okay? So you've got 18 of these tertiary segments, and those are the ones that we look for that get knocked out when there's a pulmonary embolus. And by the way, I'm not normally going to ask you the anatomy of those tertiary segments, but like I said, what is important about them is that there's 18 of them, and whenever you have pulmonary emboli, 80% of the time you have more than one. It takes out more than one segment. Okay. Tracheostomies, you may have patients that you have to do a tracheostomy on. Just be aware that the tracheostomy is going to be put in the cricothyroid junction, just below the cricothyroid cartilage. And normally when you do a patient with this, you just hook up your tubing to the trachea, you pinch the nose so that air doesn't come out through the nose, and then you can do your study like that. Okay. The tertiary bronchi, they go to bronchioles, and then they go into the alveoli. And the alveoli are the important part of your lung because this is where the exchange occurs. They look like little grape clusters. Okay. In the textbook, it says that there's about 280 to 300 million of them. I think that's what I said in my comment here. Yeah. So if you look in the first page of the lung handout, it says a single layer of epithelial cells surrounded by capillaries. Where the gas exchange occurs, there's approximately 250 to 300 million in both lungs. The reason why I say that is because they always ask questions, how many particles do we typically inject for a lung scan?
5 to 10 million.
Yeah, usually it's somewhere between, it could actually be, the minimum would be 125,000, and then the maximum could be up to like 1 to 2 million. They're just basically wanting you to be aware that you're not taking out a large number of alveoli when you do this. However, if you don't have good quality control, then you can actually create more problems than, you're actually going to be adding more emboli to what the patient already has. So you've got to be careful. I think most places now just do a CT scan, call it a day. This is what they're talking about here, is the alveoli surrounded by a lot of capillaries. These are 1 cell thick, so there's a very rapid flow of gases between the two, between the bloodstream and the okay, and then what else do we have that I wanted you to be aware of? This is general chest anatomy here. One thing you should be able to document too is what they call the pattern of how the person breathes. The tachypnea is one thing. There's another condition called hypernia. What's hypernia? No, deeply. Tachypnea is rapid. Hypernia is like they get a really, really deep breath. Okay. I'm trying to think. Okay. One of the other handouts that I gave you. This is just mainly FYI. If later on you decide to shoot for your CT, I've included a section on cross-sectional anatomy of the lungs. And this isn't it here, but there's another PowerPoint that I included that has cross-sectional anatomy for it. But basically, remember that the trachea is in front of the esophagus. It's composed of cartilage. Normally when you have a small child, cartilage isn't formed. So that's why we don't typically palpate for carotid pulses on children when we do CPR, because we don't want to collapse their airway. But taking a look at this thing here, okay, because one of the other factors that we look at is both lungs are surrounded by this membranous sac called the pleura. And the pleura, remember there's visceral and parietal pleura. The visceral is on the inside in contact with the lung tissue. The parietal is on the outside in contact with the chest wall. Remember that it's full of fluid. What's the purpose of the fluid?
Lubrication.
Okay, mainly lubrication. All 18 of those tertiary lung lobes are surrounded in their own little pleura. Okay? And the reason why is because when you get an infection or anything like that, the pleura also blocks off and protects the other segments from the spread of infection. Okay? We also have a heart that's surrounded by the pericardial sac. It's also a serous membrane, which also provides lubrication to the heart. Okay?
So each section has its own pleura, or this?
That it has its own pleura. It's all surrounded by its own double sac.
So the whole thing visceral and flow.
Yeah. It's like a continuous membrane, but as I said, the reason why it does that is so that if you do get a pneumonia or something, that segment is basically walled off and protected for the other segment so it doesn't spread. Okay? We talked about inspiration and expiration. You know, when a patient is breathing, you should have symmetrical expansion of the lungs, and also when they exhale. So the thing is, if you see one lung that's moving and the other isn't, that means either they've had one of their lungs removed or they have an obstruction. Okay? And also you should be familiar with breath sounds. Okay? Normally with pulmonary embolus there's not going to be breath sounds, but if they have pneumonia or if they have something blocking the airway, a lot of times they'll be making...
Wheezing or lung.
Yeah, you have wheezing. Wheezing was what you hear with asthma. That's that kind of a high-pitched sound, mainly towards the end of inspiration and at the end of exhalation. If you have asthma, you know what we're talking about. But, you know, an asthma problem is going to affect our scan because whenever a patient has pathology in the lung, if air cannot be exchanged at that section, the lung will divert blood away from that area, what we call physiologic shunting. So if you have emphysema and there's an area that's been damaged where there's no more air movement, your body will deliberately move blood away from that area through this process of physiologic shunting. So that's why we need to have that in the history. So our chest x-ray will show there's COPD. If we see that there's no ventilation in that area, and if we see that our xenon or whatever stays trapped in that area, then we know that that's not a pulmonary embolus.
And what's physiological shunting again? Blood diving.
Well, the body recognizes that there's not going to be any oxygen CO2 exchange in an area of the lung, so it diverts blood away from that area. And that's why our lung perfusion scan would be abnormal for that area. We don't want to get confused that it's a PE.
But with the xenon, the vent go there?
Yeah, what happens is normally when you do xenon, okay, the patient takes in they take in a deep breath, what they call a breath holding phase. And you image it for 15 seconds or as long as they can, up to 15 seconds. And that's going to show you if there's any airway obstructions. Okay? So if you don't see air going to a segment of the lung, it's probably obstructed. Okay, then you do what they call the equilibrium phase, where you have the patient breathe the xenon in and out. And what happens then is the xenon will gradually diffuse into those areas that have been damaged. Okay? But the thing is, it doesn't leave. So that's why when the patient exhales and you go to the washout phase, the xenon stays there. So you're going to do typically one picture that's 15 seconds, then you do equilibrium, where you do a series of maybe 3 or 4 pictures, 15 seconds each, while the patient is continuously breathing and recirculating the xenon. And then after about a minute of that, then you go to the washout phase, and then you take a series of 15-second pictures over maybe the next 3 to 5 minutes for the washout. Okay? But one of the examples that they give of how the lungs work, it's like when you pull a plunger back on a syringe, so the air goes in, and then, you know, when you push it forward, it goes out. We already talked about atmospheric pressure. If you have exhaled your lungs, okay, the pressure inside your lung is the same pressure as on the outside, so you've got 760 millimeters of mercury. When you breathe in, okay, just even a minor change. Notice that here 758 millimeters of mercury, that's enough to cause air to go into your lungs. Okay, and that's all it is. Under extreme conditions, now normally the main muscle for breathing is the diaphragm, but in situations where patients are having difficulty breathing, if they use what we call accessory muscles, which would be the costal muscles, that's a very dangerous sign. And a lot of times when people have that, you'll see this on infants and on adults with adult respiratory distress syndrome. When they breathe, the lung actually looks like it's collapsing in, or the chest looks like it's collapsing in. You ever seen that?
See their ribs too, kind of?
Yeah,
Their ribs are kind of defined.
yeah, yeah. But I mean, it almost looks like their chest is caving in on it when they have to use those accessory muscles. Okay? I'm not going to worry too much about this. This is, if we were taking an anatomy class, then this would help it. I just thought there were some interesting things here. Okay, expiration, basically the diaphragm just moves back into its original position. That pushes the air out. Let me think here. You guys can look through this if you want. If you were going into respiratory therapy, you would be looking at this thing here. You ever seen these? Yeah. This is what they, you know, when you have the patient breathe into that big drum type of a thing,